The term TMD, temporomandibular disorder, is an umbrella term encompassing many conditions. RDC, TMD Research Diagnostic Criteria, TMD was developed by Dworkin et al. In 1992. The RDC, TMD focused on the psychosocial aspect of chronic pain and not just on the biophysical aspect. That meant the focus was no longer on finding possible physical problems. The OPPERA study was a landmark international collaboration and indicated the physical, psychosocial and genetic aspects of TMD. In 2016 the IASP published the ICD-11 classification for orofacial pain, which included TMD as a chronic primary pain. Chronic pain is defined by the IASP as pain occurring for more than 3 months. It is pathological, whereas acute pain is protective. The IASP classification ICD-11 classifies chronic TMD under chronic primary pain (CPP). Chronic primary pain is defined as pain occurring for more than 3 months and with no pathology at the site of pain. This means we should not be carrying out any irreversible procedures peripherally. As seen in this classification, there are 5 subheadings under CPP. We are mainly dealing with chronic primary headache or orofacial pain. Under this you have 1. Chronic migraine. These usually may be with or without aura and may be associated with nausea and photophobia. Migraines are usually managed by a patient's medical practitioner. They are typically unilateral, pulsating quality. Worsens with physical activity. 2. Chronic tension-type headaches. These occur typically 2 hours per day on 15 days in a 3-month period. Pain does not worsen with physical activity. These are usually bilateral. 3. Trigeminal autonomic cephalalgias or TACs. These are unilateral with autonomic features such as lacrimation, rhinorrhea, nasal congestion and eyelid edema on the affected side. These include paroxysmal hemicrania, cluster headaches, Suna and hemicrania continua. 4. Chronic temporomandibular disorder, which will be discussed separately. 5. Chronic burning mouth pain. This is a neuropathic pain condition often referred to as burning mouth syndrome. I like to refer to these as dysesthesias. These can indicate a burning sensation or a feeling of dryness without hyposalivation. 6. Chronic primary orofacial pain includes other neuropathic pain conditions such as PDAP, persistent dentoalveolar pain, and PIFP, persistent idiopathic facial pain. Recent evidence indicates that some people may be born with a susceptibility for chronic pain. It is suggested that 20% of acute pain may become chronic. Remember that chronic pain is pathological. Environmental factors may also through epigenetics lead to activation or silencing of gene activity, which may lead to pain phenotypes progressing onto chronic pain. Gene changes may occur through 3 ways. 1. DNA methylation. 2. Histone acetylation, which causes gene expression, or deacetylation, which leads to gene repression. 3. Non-coding RNA changes. This means that due to inherited genes or changed genes a person could be primed to becoming a chronic pain sufferer. So in summary, chronic primary pain is where pain has been present for more than 3 months and the pathology is not at the site of pain. Typically this is true in myogenic TMD and some arthrogenous TMD. Chronic burning mouth and other neuropathic conditions are examples. Chronic secondary pain is where there may have been an initial trigger for the pain, but after 3 months then the pain has its own pathology and so is similar to CPP. It is pathological pain with sensitization. TMJ arthritis is an example of this. It should be noted that disc displacement in the TMJ means that the disc has already undergone chronic change and no evidence-based procedure currently available that will change that. The TMJ and disc have the ability to adapt well through life. In the same way, there is currently no procedure that is evidence-based available to reverse TMJ osteoarthritis. It is also important to note that CPP-TMD is a condition that is part of a chronic overlapping pain conditions (COPCs). These include TMD, fibromyalgia, vulvodynia, chronic fatigue syndrome, painful bladder syndrome, endometriosis, chronic tension-type headaches, migraine and chronic lower back pain. These patients may also present with fatigue, sleep impairment, impaired cognitive function, physical dysfunction, anxiety, depression. The ICOP classification for orofacial pain 2020 is divided into 7 categories as seen in this slide. 1. Orofacial pains attributed to dento-alveolar and anatomically related structures. These mainly refer to acute pain conditions and associated pathology, for example dental pain. 2. Myofascial orofacial pain, which refers to both acute and chronic pain conditions. The chronic pain categories here are the chronic primary pains, that is, the pain has been present for more than 3 months and there is no pathology at the site of pain. 3. Temporomandibular joint (TMJ) related pain refers to arthritic and disc displacement conditions. Acute primary TMJ pain requires acute pain medications and rest. In the chronic TMJ pains including chronic arthritic pain, this is better regarded as chronic secondary pain where there may have been an initial trigger but after 3 months the pain is the pathology and there is no pathology at the site of pain. 4. Orofacial pain attributed to lesion or disease of the cranial nerves. These are specific diagnoses which require management with either surgery, e.g. trigeminal neuralgia, or neuropathic pain medications such as nortriptyline, gabapentin, pregabalin, carbamazepine, oxycarbazepine. 5. Orofacial pains resembling presentations of primary headaches. In this category you can also have mid-facial migraines as well as trigeminal autonomic cephalalgias and neurovascular orofacial pain. 6. Idiopathic orofacial pain. These would include PDAP, formerly atypical odontalgia, and PIFP and burning mouth. TMD temporomandibular disorder is an umbrella term and under the DC-TMD classification have many sub-diagnoses under the term. In my opinion, this classification does nothing to direct clinical management. However, under the ICD-11 classification some of these subheadings come under chronic primary pain, CPP, where there is no pathology at the site of pain. These include myogenous TMD, some arthrogenous TMDs, headache attributed to TMD. These separate the other TMD condition under DC-TMD, which are truly surgical management options. Example: fracture, coronoid hyperplasia. Chronic secondary pain, which is similar to CPP but where there may have been an initiating trigger but after 3 months the pain becomes the pathology and you treat this in a similar way to CPP. As mentioned before, the management of CPP involves non-surgical management and treatment which is reversible and no peripheral procedures are carried out. Comorbidities for TMD include headaches associated with TMD. 62% of TMD patients may have ear symptoms without ear pathology. Polonoita et al., 2019. Chronic overlapping pain conditions (COPC), which include fibromyalgia, TMD, irritable bowel syndrome, chronic lower back pain, among others. Chronic pain sufferers have a higher number of first-degree relatives with depression, anxiety. Corrigan et al., 2011. It is good to take these into account when assessing the chronic orofacial pain patient. Pain history. Use Socrates. This involves site, onset, character sharp, dull, annoying, aching, etc. Radiation. Ear symptoms. Associations such as headaches. Timeline. Are the symptoms constant or intermittent? Exacerbating or relieving factors. Example: pain on eating or touch. Pain severity, pain level out of 10. The examination clinically would involve palpating extra-orally the temporalis, TMJs and masseter. Recording interincisal mouth opening, normal is greater than 35 mm. Intra-orally palpating the masseters. The pain scores should be recorded. See the clinical photos. The management of chronic pain. The following are some of the things that the patient can do for themselves. Mindfulness-based stress reduction (MBSR). Reduce catastrophizing. Exercise to activate body's own pain management system. Sleep hygiene. Poor sleep can exacerbate pain. Love and reward pathway. It has been shown that this will activate different area of the brain and will help reverse some of the focus on the pain center. Chronic primary pain (chronic TMD). Management begins with the explanation of the condition to the patient so they have an understanding of the problem and what can help. This plus providing the patient with non-surgical self-help advice will form part of the initial CBT. Other CBT could be gained through YouTube. Oral appliance in the form of a flat acrylic hard plate with full occlusal coverage helps, possibly through neuromodulation and placebo. Physiotherapy probably works in a similar way. Pharmacotherapy. Acute pain medications don't really have a place in chronic pain management. Neuropathic pain medications such as tricyclic antidepressants, e.g. nortriptyline, and anticonvulsants, e.g. gabapentin and pregabalin, are successful in reducing sensitization. Also with the other treatment approaches already mentioned. Acupuncture is a reversible treatment and has been shown to be useful. There is no evidence to show that Botox should be used for TMD. Arthrocentesis lacks evidence and does not make sense for a chronic primary pain which by definition does not have any pathology at the site of pain.